Loss is a normal part of the human experience. We have to say goodbye to people, dreams, hopes, homes, and treasured objects. Some losses come with growth, like outgrowing a toy that you loved as a little child or giving up your childhood dream of becoming a firefighter. Loss allows us to change, develop, and fulfill our human potential. It might be a planned loss, an expected loss, or a sudden loss. Loss can be difficult but beneficial, and it can also be devastating and debilitating. Grief is the subjective emotions and affect that are a normal response to loss. Grieving, or bereavement, refers to the process by which a person experiences grief. It affects both the content of their thoughts and the process. Anticipatory grieving occurs when people are facing an imminent loss and begin to deal with the possibility of the loss in the near future, like perhaps the patient having an amputation the next day. Mourning is the outward expression of grief. Some rituals of mourning include having a wake, sitting Shiva, religious ceremonies, or having a funeral. Maslow's hierarchy of needs tells us what motivates human action. Basic physiologic needs have to be met first: food, water, air, and sleep. Safety needs then have to be met with a safe place to live and work, then security and belonging needs with satisfying relationships. Then come self-esteem and self-actualization. If any of these needs are taken away or they're not met, the person will feel a loss. Some examples of losses according to Maslow. Physiologic losses would include an amputation, mastectomy, hysterectomy, and loss of mobility. Safety losses include domestic violence, child abuse, and public violence. Loss of security or sense of belonging include the loss of a loved one or changes in a relationship like a marriage, the birth of a child, divorce, or illness. Self-esteem losses include broken relationships or the loss of a job. And self-actualization losses include having to give up your hopes and dreams. Elizabeth Kubler-Ross developed a model of 5 stages of grieving. First is denial. It's the shock and disbelief regarding the loss. Then anger, which might be expressed toward God, family, friends, or even the healthcare workers. Bargaining occurs when the person asks God or fate for more time to delay the loss. Depression happens when the awareness of the loss becomes acute. And acceptance is when the person shows evidence of coming to terms with the loss. John Bowlby was a British psychoanalyst. He described the grieving process in 4 stages: experiencing numbness and denying the loss, emotionally yearning for the lost loved one and protesting the permanence of the loss, experiencing cognitive disorganization and emotional despair with difficulty functioning in the everyday world, and reorganizing and reintegrating the sense of self to pull life back together. George Engel described 5 stages of grieving: shock and disbelief, developing awareness, restitution, resolution of loss, and recovery. Marty Horowitz divides normal grief into 4 stages of loss and adaptation. Outcry is the realization of the loss. Denial and intrusion is moving back and forth between denial and intrusion. Working through happens when you still think about the loss, but you start finding ways to manage life after the loss. And completion, life starts to feel normal again, although it's different. Tasks of grieving or mourning involve active rather than passive participation. Therese Rando describes tasks of grieving as the 6 R's. Recognize, experiencing the loss and understanding that it's real. React is the emotional response to the loss, where you feel the feelings. Recollect and re-experience. The memories are reviewed and relived. Relinquish, accepting that the world has changed because of the loss. Readjust, beginning to return to daily life, the loss is less acute. Reinvest, accepting the changes have occurred and re-entering the world. William Worden had some tasks of grieving as well: accepting the reality of the loss, working through the pain of grief, adjusting to an environment of change due to the loss, and emotionally relocating that which was lost and moving on with life. People have many and varied responses to loss. They may express their grief through thoughts, words, feelings, and actions. Nurses need to use a holistic model of grieving that encompasses cognitive, emotional, spiritual, behavioral, and physiologic dimensions. Cognitive responses to grief include grieving can cause a person to change their beliefs about themselves and the world. The person needs to make sense of the loss, and they might question accepted ways of thinking. Questioning can help them accept the reality of why someone died. Keeping the lost one present helps to soften the effects of the loss while assimilating its reality. Common emotional responses to loss are anger, sadness, and anxiety. Anger and resentment might be directed toward the dead person, family members, healthcare providers, or the institution. They may feel guilt over things that they didn't say or do. They may feel hatred and want revenge. Eventually, the grieving person begins to reestablish a sense of their personal identity, direction, and a purpose for living. They learn new ways to manage life and form new relationships, and thinking about the loved one no longer causes the painful feelings. Spiritual responses come from the values and belief systems that the person has. The grieving person may become disillusioned and angry at God or other religious figures. Nurses also minister to the spiritual needs of patients and families. Nurses can provide opportunities for people to share their suffering and promote a sense of well-being. Behavioral responses to grief can be the easiest to observe. A grieving person may function automatically without giving much thought into what they're doing, which may indicate that they feel numb. They may cry uncontrollably or be restless. They may be irritable and hostile to others. They may look around for the deceased. Suicide and homicide may be extreme responses if the person can't move through the grieving process. Physiologic responses are often a source of anxiety and concern for the grieving person, their family, and their friends. They may complain of insomnia, headaches, poor appetite, lack of energy, palpitations, indigestions, and changes in the immune and endocrine systems. Everyone grieves for lost loved ones, but rituals and habits surrounding death vary from culture to culture. Each culture defines the context in which grieving, mourning, and integrating loss into life happen. Universal reactions include the initial shock response, social disorientation, attempts to continue a relationship with the deceased, anger with those they see as responsible, and a time for mourning. Each culture defines acceptable ways to mourn, and nurses need to be sensitive to the cultural differences. Cultural bereavement rituals have roots in major religions, and practices regarding death will frequently guide mourning. African Americans typically have a viewing for the deceased in church before they're buried in the cemetery. They may have public prayers, wear black clothing, and decrease their social activities. The mourning period can last anywhere from a few weeks to several years. For Muslim Americans, cremation is not permitted. They have 5 steps of the burial procedure that specify washing, dressing, and positioning the body. The washing must be done by a Muslim of the same gender. Some Haitian Americans practice voodoo, which is also called root medicine. This practice was derived from Roman Catholic rituals and cultural practices of Western Africa. It's the practice of calling on a group of spirits you periodically make peace with during specific events in life, such as death. Chinese Americans have strict norms for announcing death, preparing the body, arranging the funeral and burial, and mourning after the burial. Burning incense and reading scripture help the spirit of the deceased into the afterlife. The family may put bowls of food on the table for a year after the death of the spirit. Buddhist Japanese Americans view death as a life passage. Family members may bathe the deceased with warm water and dress the body in a white kimono after purification rites. Family and friends may bring gifts or offer money to the deceased while praying and burning incense for 2 days. Most Filipino Americans are Catholic and may wear black clothing or armbands. Family and friends place wreaths on the casket and drape black cloth on the home of the deceased. Family members may place an announcement in the newspaper asking for prayers and blessings on the soul of the deceased. Vietnamese Americans are generally Buddhists who bathe the deceased and dress them in black clothes. They may put a few grains of rice in the mouth and place money with the body so they can buy a drink as they move towards the afterlife. The body may be viewed in the home before burial. Hispanic Americans are predominantly Roman Catholic. They may pray for the soul of the deceased during a novena, which is a 9-day devotion, and a rosary, which is a devotional prayer. Luto means mourning. During this period, they may wear black or black and white and behave in a subdued manner. Showing respect for the deceased may include not watching TV, going to the movies, listening to the radio, or attending social events for some time. They may decorate the grave with flowers and crosses. For Native Americans, the medicine man or priestly healer helps the family and friends of the deceased to regain spiritual equilibrium. Baptism ceremonies of the deceased are seen to help ward off depression for the bereaved. A ceremony held at the burial ground, where the grave is covered with a blanket or cloth, signals the end of mourning. The cloth is later given to a tribe member. A dinner with singing, speeches, and contributing money completes the ceremony. An Orthodox Jewish custom is for a relative to stay with a dying person, so leaving the body alone after death is considered disrespectful. The body may be covered with a sheet and the eyes closed. The body should stay covered and untouched until a family member, rabbi, or Jewish undertaker can begin rites. Organ donation is permitted, but autopsy is not unless it's required by law. Burial needs to happen within 24 hours unless it's delayed by the Sabbath. Shiva is a 7-day mourning period that begins on the day of the funeral. Nurses have many opportunities to individualize care when working with grieving people. The nurse should encourage families to discover what is effective and meaningful for them in the grieving period. They might offer prayer or to stay with the body. They can allow loved ones to perform rituals. Memorials may also be built, such as the memorial in Oklahoma City for those killed in the Alfred P. Murrah Federal Building. Disenfranchised grief is grief over a loss that is not or cannot be openly acknowledged, mourned publicly, or supported socially. Circumstances that can result in disenfranchised grief include a relationship that has no legitimacy, the loss itself is not recognized, the griever is not recognized, or the loss involves social stigma. The grief process is more complex because the usual supports that facilitate grieving are absent. Kin-based relationships get the most attention in cases of death. Other relationships, like neighbors, foster parents, friends, lovers, or caregivers, may be long-lasting and intense, but the people suffering may not be able to mourn publicly or with social support, such as same-sex partners, those living together that are not married, or extramarital affairs. Other losses may not be seen as socially significant. A prenatal death, an abortion, giving up a child for adoption, the death of a pet, or a job loss. Nurses and hospital chaplains may have disenfranchised grief when their need to grieve is not recognized. Nurses who work in organ transplant or donation or oncology work closely with families and can create strong bonds. The losses can be significant for these nurses, but there's seldom a place or time to grieve. Chaplains may feel that they have to be strong when they're dealing with death and may not recognize their own need to grieve. Complicated grieving is a response outside the norm. It occurs when a person is void of emotion, grieves for a prolonged period, or has expressions of grief that seem disproportionate to the event. Previously existing psychiatric disorders may complicate the grief process, so the nurse needs to be alert to those with psychiatric disorders who are also grieving. Grief can cause major depression in a person who has a history of depression. For some people, grief is particularly devastating because their personalities, emotional state, or situations make them susceptible to complications. People who are vulnerable to complicated grieving include those with the following characteristics: low self-esteem, low trust in others, a previous psychiatric disorder, previous suicide threats or attempts, absent or unhelpful family members, an ambivalent, dependent, or insecure attachment to the deceased. An ambivalent attachment happens when at least one partner is unclear on how the couple loves or does not love each other. A dependent attachment happens when one partner relies on the other to provide for their needs without necessarily meeting the other person's needs. And an insecure attachment it usually forms during childhood, especially if the child has learned fear or helplessness. Some experiences increase the risk of complicated grieving and can lead to vulnerability. The death of a spouse or child, the death of a parent, particularly if it happened in childhood or adolescence, a sudden, unexpected, or untimely death, multiple deaths, and death by suicide or murder. Complicated grieving is a unique and varied experience, and the person can experience physical and emotional reactions, such as an impaired immune system, increased adrenal cortical activity, increased levels of serum prolactin and growth hormone, psychosomatic disorders, increased mortality from heart disease, depression, anxiety, and panic disorders, delayed or inhibited grief, and chronic grief. For the nurse to support and facilitate the grief process, they must observe and listen for cognitive, emotional, spiritual, behavioral, and physiologic cues. What is the patient thinking? How do they feel? What are their values and beliefs? How are they acting? And what is happening in their body? The nurse needs to be familiar with the phases, tasks, and dimensions of the human response to loss, but also recognize that each person is unique. There are 3 critical components to the assessment. Adequate perception regarding loss. What does this loss mean to this patient? Adequate support while grieving the loss. Who can meet their emotional and spiritual needs for love and support? And adequate coping behaviors during the process. What does their behavior look like? The nursing diagnosis is based on subjective and objective assessment data of the patient. Some diagnoses for a person experiencing grief might be grieving, complicated grieving, risk for complicated grieving, and anticipatory grieving. Examples of outcomes: the patient will identify the effects of their loss, identify the meaning of their loss, seek adequate support while expressing grief, develop a plan for coping with the loss, apply effective coping strategies, recognize the negative effects of the loss on their life, seek or accept professional help if needed to promote the grieving process. The nurse helps the patient to examine and make changes and move through the grief process. Some of the patients may take one step at a time, and sometimes they seem to go over and over the same ground again and again. Cognitive responses are connected to the emotional turmoil that accompanies grieving. Exploring their perception of the loss and what it means to them can help alleviate the pain of the initial emotional response in grieving. It's important to listen to whatever emotions the person expresses, even if the nurse doesn't agree with the feelings, like if they're angry at the deceased or God. Adaptive denial is when the patient gradually adjusts to the reality of the loss. It can help the patient let go of previous perceptions while creating new ways to think about themselves, others, and the world. Taking in the loss all at once can be overwhelming, but dealing with it in smaller increments seems more manageable. The nurse can help the patient reach out and accept the support that others can give. The nurse can help patients find information, support groups, and other activities related to the grieving process. Communication is key to promoting coping behaviors and encouraging the patient to examine their experience and behaviors for ways they might be coping with the loss. Intervention involves giving the patient the chance to look at how they have coped with loss in the past, review their strengths, and renew a sense of personal power. Remembering and practicing old behavior may help them try new methods in this new experience. As a nurse, you can encourage the patient to take care of themselves, to eat, sleep, exercise, and find some comforting activities that help them feel better. Something you can say to a grieving patient is, "I want you to know I'm thinking about you." Evaluation of progress depends on the established goals. Review the tasks and phases of grieving to see what the patient's status is. Maybe they're experiencing denial, or maybe they're showing signs of recovery and healing. Patients who are grieving need the support of someone they can trust with their emotions and thoughts. The nurse must be willing to examine their own attitudes about loss and the grieving process in order to be seen as trustworthy by the patient. Taking a self-awareness inventory and self-evaluation may mean asking yourself some of the following questions. What are the losses in my life and how do they affect me? Am I currently grieving a significant loss? Does my loss affect my ability to be present for my patient? How am I coping with my loss? Can I keep appropriate boundaries with the patient? And do I have the strength to be present and facilitate the patient's grief?